our next speaker is Dr. Jack Bromley, and he will be talking about palliative care and pain management. The few facts that I will be mentioning this morning is a very condensed summary of Dr. Bromley's extensive work and teaching experience, and a long list of appointments and positions. We'd be here for quite a while if I started to Dr. Bromley spent his early years in Three Hills and also in Papua New Guinea, as his parents were missionaries. He received his medical training in Calgary and Halifax. He had a general practice in the Northwest Territories and in Papua New Guinea before coming to Red Deer in 1993. He has been heavily involved in medical education, which is the training of family doctors and paramedics for rural practices, and in medical politics. He might be interesting to talk to after. He retired from hospital and office practice in 2022, but is still involved with long-term care, hospice care, and dementia assessments. He is married to Susan, and they have 4 children and 11 grandchildren. We are very fortunate that he still is committed to the provision of full-spectrum family medical practice. Please welcome Dr. Bromley.
Thank you. I guess I should be impressed with myself. What I wanted to talk about today is primarily having to do with palliative care. And for those of you, so often there's kind of a confusion around what palliative care actually is, what it means. A lot of people think of it as kind of giving up, and it's kind of what we do when we give up on trying to keep people healthy. And that's really not the case at all. So palliative care is a specialized interdisciplinary form of medical care, and it's focused on providing physical and emotional and spiritual support for people that are living with chronic conditions or serious illnesses. We typically think of palliative care at the end of life, but it doesn't have to be that. It's a different kind of focus of care that can apply throughout life, really. But anytime people are encountering serious medical conditions that they need to live with for a period of time, then palliative care is what we're looking at. So what it does is it helps to manage physical symptoms as well as emotional stressors. It focuses on goals of care. It focuses on your values and what is important to you. And it has benefits for patients as well as for caregivers. Palliative care deals with, as I mentioned earlier, symptom control. How do we manage difficult symptoms? And the first one we often think of is pain, and that's very true. Pain comes in many different forms, so we all are familiar with the pain of a broken bone or of an injury where we get bruised, we pull a muscle, we have arthritis, we have pain in our joints. Those are the common kind of body pains that most of us deal with, but often when we're in palliative care, we're dealing with a different kind of pain. There's pain related to damaged nerves that can be part of a cancer process. It can be part of an injury as well, but in palliative care, it's more often dealing with cancers that's spreading and invading into nerve tissue and causing terrible pain by irritating and inflaming nerves. That's a very different kind of management than it would be for a simple physical kind of an injury. There's visceral pain, where you have pain in the internal organs related, again, typically to a cancerous process that is invading those kind of tissues and causing a very different kind of pain. And so There's different approaches to that, because not everything works. There isn't just kind of one way of dealing with pain. Another kind of pain has to do with pressure. For instance, if you have a cancer that's involving bones, the cancer is growing inside the bone, there's nowhere for the pressure to go. It's contained within the bone, and that can be a very intense and difficult thing to manage. Another very common set of symptoms has to do with the stomach and the bowels. So nausea, vomiting, those are very common and often very difficult kind of things to manage. And again, there isn't one simple way of managing it. And that's where the expertise of somebody who deals in palliative care can use different forms of treatment for that. Constipation, we kind of think of as a nuisance, but in many instances it can be a very troubling and difficult problem. Shortness of breath is another common one, where people, for various reasons, not necessarily because of lung disease, say from smoking or emphysema or those kinds of things, there's other things as well that will contribute to that. And there's this terrible feeling of breathlessness where you just can't get your breath. And that's a common kind of a symptom that we deal with. Fatigue, tiredness, that's very, very common. And then there's delirium. So delirium is where the brain is involved and things go off kilter. The brain is not processing things normally, and people will hallucinate, or they will act out in very unusual ways. So those are all the common kinds of things that we find in palliative care. In the Red Deer context, we have palliative care provided at the hospital. There's a particular unit that focuses on palliative care. Unit 32P is the one that is there. We have a palliative care team that works in the community that's provided through home care. And then we have the hospice. And I'll talk about the hospice a little bit later. But all of these palliative teams involve a variety of people that have different kinds of expertise. So there are doctors, but doctors only provide a part of that care. We have general practitioners, GPs, family doctors, who are kind of the ones who typically provide the first level of care. We have specialists who their entire focus of care is in palliative medicine. And we have a couple of these doctors in Red Deer. One is Dr. Maureen McCall, you may know, Dr. Stephen Yam. But then we also have consulting specialists that we have access to who would practice in Calgary and Edmonton. And these would be people that would have a higher level of education and specialization in palliative care, and can be accessed for advice over the phone, or will arrange to see patients as needed. We have other specialists who provide care in this area that may be just a small part of their practice. For instance, we have surgeons who are typically involved in any number of different kinds of surgeries, but sometimes the focus will be on providing symptom control rather than disease control. And so that would be considered palliative. In the X-ray department, we have radiologists who provide interventional care, which means they will put tubes into various places. They'll put a tube in the chest, and it'll drain off fluid if the chest is filling up with fluid. And that's a palliative thing to relieve the pressure, to let you breathe more easily, but it's not curing the underlying disease process. And then we have radiation oncologists. These are physicians who use nuclear medicine to radiate tissues to shrink the size of a tumor, for instance, and provide relief. And all of these are aimed at controlling symptoms rather than trying to, once and for all, cure the disease, because the disease has gone beyond the point where there actually is any practical way of eliminating it altogether. There are many others that are in the team providing care. There are nurses, there are nurse aides, there are home care workers, healthcare aides, we have counselors, we have people, for instance, in the hospice, we have professional cooks, and we have, of course, cleaning staff. All of these people are providing aid and care to the person who is in need. And I guess, just to reinforce, in palliative care, there's a point where certain continued interventions are just no longer helpful. You can't just keep giving chemotherapy forever. At some point, the chemotherapy is causing more damage than it is helping. And so there's a limit to that, and at some point it makes sense to stop. Similarly with surgeries. Certain surgeries are very helpful, very beneficial, and can be curative at a certain stage, but at later stages of disease, they're no longer helpful. And so there's a point where it makes sense to stop looking at what can we do to completely eliminate this disease process and focus on managing the symptoms. As I said before, they don't have to be mutually exclusive. Palliative care can be part of the process in this whole journey, and it's helpful if it's thought of in that way. To talk about hospice care, I don't know how many of you are familiar with the Red Deer Hospice. We have a pamphlet here. Yeah, certainly a number of you would have had loved ones going through the hospice and would know it from first-hand experience. There's a booklet at the front here, if any of you are interested, from the hospice, just describing the facility. It's a beautiful building. It's 16 beds. The rooms are large. They're bright. They have sofas for families. They pull out sofas so families can sleep there. It's available for people who are expected not to live more than 3 months. So you can never predict with certainty what anyone's life expectancy actually will be. But you can give a rough estimate, and if it's expected that they will pass away within 3 months, and that would make them eligible to stay at the hospice. You don't have to have a doctor to admit you. We have doctors who work there on call to take care of people who don't have their own doctor. If your doctor does work at hospice, then of course they would continue to see you and care for you there. There's no charge for staying at the hospice. There may be some costs involved if you require certain medications that are not covered by Blue Cross, and more specifically by Palliative Blue Cross. So there's a Blue Cross provision for people in palliative care that provides extra funding for most medications. But sometimes there'll be some medication that may not be covered, and then that might be a cost, but the cost of staying at the facility is not borne by the patient or the family. The facility is funded by Alberta Health Services to some extent, but it's also funded to a very significant degree by donations from people in the community. What I hear from people who come to the hospice, it's the families that usually just heave a huge sigh of relief, that the pressure that they felt at home of managing all of the care for their loved one is now carried on by professional people around them, and they can just be with that person and just spend time and talk and read or play music or whatever it may be. The rooms are large and accommodate a lot of people, so families can come any time of day, 24 hours a day. They can come and go. As I said, they can stay, they can sleep there if they want to. Meals are provided, and there's counseling that's provided. and some of you I know can speak from experience as how that affected you in terms of your care for the loved one. I'm not sure what else to say. I'm certainly happy to answer any questions that you have about palliative care or about the hospice. But I also like to get some feedback from those of you that have had experience there to tell us how you found things went. But I think the most important, I think, of what I want to communicate is that palliative care is actually a very significant and a very sophisticated form of care. It's not giving up and saying, you know, we're no longer going to worry about trying to help you. We're just going to kind of patch things over. That's not what it is at all. So, any questions?
I just want to ask about what pain medication, about what pain medication is even offered at the hospice, because I understand it's rather limited.
I would not describe it as being limited at all. We provide a large variety of different kinds of pain management depending on the kind of pain that's being experienced. Most commonly we're using narcotics. So there's morphine, there's hydromorphone, there's methadone, there's sometimes codeine, but that's very seldom used. It's not a very good drug for the most part. But of course we'll also use Tylenol or Advil, ibuprofen, those kinds of things. But usually it's the big guns that we're using, like morphine and hydromorphone. And these are given either orally or by injection. Most commonly in later stages of life, they're given by a needle under the skin, what we call chlysis, and the needle is just left there with a very small amount of fluid that can run in, or it can just be used strictly for injections. So they're not being poked all the time, the needle's already there. And then the morphine or hydromorphone can be injected under the skin, and typically it's given every 4 hours around the clock, because that's typically how long that sort of medication is effective. So it's given around the clock, day and night. But then there's breakthrough medication. So if with that kind of medication they're not getting good control, then every hour they can get extra injections on top of that. And if they're needing lots of extra injections, then the regular hour or 4 hourly injection dose is increased. Another medication I did not mention is fentanyl. Fentanyl is given as well, but not as commonly as the morphine and hydromorphone. There's no limit to how much pain medication is used. It's whatever's needed to control the pain. We're not worried about addiction. That's not an issue that concerns us in the hospice particularly. So I'm not sure if there's any other, other forms of pain control would be, for instance, radiation. I mentioned the radiation oncologists at the cancer clinic. They will radiate certain areas to provide pain relief. If you have a tumor growing in your spine, that can be just terribly, terribly painful. And radiation can provide some relief by shrinking the tumor. What other things? There are other medications that go along with the pain medication to control anxiety and I mean, sometimes people hallucinate and this delirium that I mentioned, where the brain is not functioning normally. Then there are other medications that are used to control some of those kind of symptoms. So there are the common medicines that you may be familiar with, like Ativan or lorazepam, clonazepam. The PAM drugs are the drugs that just provide a sedative, calming kind of effect. so they can be used. But then there's stronger antipsychotic kind of medications that might be necessary. And these can have a double benefit, sometimes for nausea, but also for agitation and hallucinations and that kind of thing. And a common one you may have heard of is Haldol. That's an old drug that was around back before I was in med school. And then there's lots of newer ones that are similar that might be used. But it's the old ones that typically are used more often in palliative care. Yes? Sorry, there's a question at the back.
Probably don't need a mic.
Can you comment a little bit on what we know about the introduction of pain medications with things like Alzheimer's and dementia?
The interruption of pain medication and Alzheimer's and...
Interaction, like,
Oh, I see.
what do we know about, does that aggravate some of the symptoms of dementia, certain pain medications?
Well, certainly there is an interaction there. The pain medication, typically the narcotics, will suppress the brain. If you get enough narcotics, they put you to sleep. And if you get enough, they'll kill you by putting you to sleep permanently. So they suppress brain activity, and with Alzheimer's or other forms of dementia, the brain is not functioning at normal capacity. So anything that suppresses brain activity or will aggravate that. So all the drugs that I've been talking about, like the lorazepam or Valium, Ativan kind of drugs, the antipsychotics, those all suppress brain activity, and so will aggravate Alzheimer or dementia symptoms because they're kind of dulling the brain further.
So as a physician that might be treating both Alzheimer's and dementia and then pain coming from perhaps other sources, it's a matter of weighing like how important the pain medication is versus how important
Exactly.
everyday function is.
Yeah, exactly. Because if you have an Alzheimer's patient who's in terrible pain, what do you want to do?
Yeah, exactly.
Not treat their pain because it's going to dull their brain? No. So you're always using your judgment to provide what is necessary to control the symptoms without overdoing it and causing side effects. All of these drugs I'm talking about have significant side effects, and that always has to be kept in mind when you're treating patients. And just stepping back a bit into general practice, every drug that I ever prescribed has side effects. You know, aspirin, Ativan, Imodium, or for bowels, and Ativan for anxiety, and sleeping pills. You know, that nice little blue pill that helps you sleep at night. It's a terrible drug. It has side effects. So you always have to be aware that anything you prescribe, anything you take, has side effects.
On a quick other topic, if I could just comment too, you mentioned lots of services that are available, and having gone through palliative process here fairly recently, I found that the services in Red Deer and the people in particular are amazing, amazing. One thing that didn't get mentioned though that I found was critical is seeking out spiritual care coordinators at places like the hospital as well. And just a thought on that is like a lot of times, we sort of think of, oh, okay, I'm seeking out that professional for my loved one that's going through this, but like seek out that professional for you because you're going through this too. So really critical that there's, if you need it, you have an eye on those people that are backing you spiritually, because the essence of going through that process is, that's the deepest level of processing, and maybe the most important, in my opinion. But yeah, so just put that out there.
Yeah, I would agree. It's the caregiver that is being treated very much along with the patient.
I have the microphone, so I was wondering if I could ask one quick one.
Are you pulling rank?
I think so. I do bump into people who are kind of terrified about that last moment before they die and worry about a really uncontrolled level of pain. And so I wonder if you could say something about that and maybe something about palliative sedation.
Okay. So the medications that I'm talking about, particularly the narcotics, as I said, there's no upper limit to and the dosage that is whatever is needed is given. And so there's a certain point where some side effects may kick in, and then you have to be looking at alternative forms of narcotics. And so often we'll switch from one to another because when they're getting toxic side effects on morphine, we'll switch to hydromorphone. Or maybe we'll switch to methadone or to fentanyl. So there's back and forth that way. But sometimes, despite every effort, the pain is just so overwhelming that you reach a point where it's just not helping. Or now the side effects are such you can't escalate the dose any further. And then they may need to be sedated to manage their symptoms. So there's a thing called palliative sedation, which is a form of care that's typically in the very last days before someone passes away, where they're in such distress from their symptoms that you tried everything and nothing is controlling it. So you're sedating them with medication, and the typical drug that's used is called midazolam. So that's another one of those kind of PAM drugs that I talked about. This is the one that became famous when Michael Jackson died. His doctors were giving him midazolam to help him sleep, which is crazy. To me, it's kind of unbelievable, but anyway. It's a very powerful sedative that can be titrated or dosed gradually up or down, depending on how much you need. And the intent there is to give enough sedation that it takes away their experience of this kind of pain or whatever other symptom that is really overwhelming their mind, to sedate them to the point where usually they're not completely asleep. They can still be awake and talk, and they're kind of in and out. But it's not to just kind of put them right under and just kind of leave them there. It's to keep them in that balance where they have the benefit of the sedation without being completely put to sleep. Now typically they'll sleep maybe 20 hours a day, so they will be asleep most of the time, but they're not in a deep kind of a sedated coma. Yes?
Hi, you wanted, my wife died in the hospice a few years ago here, and the service and everything was great. The hard part was through Alberta home health care getting her in there. They mentioned 120 days, and I mean, she couldn't eat, swallow, or anything for 2 weeks, and we got her in there for the last 4 days. And the treatment there was just excellent. I can't say enough good things about how good the hospice was, as well as they provided grief care to me by phone, or if you wanted to go in and see them. I had a lady call me for about 10 times, and we talked, and it was very good. So I just want to say good things about it. Thanks.
Yeah, the problem of getting, the bed availability is an issue. Up until a couple of years ago, there were 8 beds, and now there's 16. So that's improved things a lot, but still, sometimes there's a wait where people are...
Well, it depended on which healthcare worker it was. One said, oh, her bowels sound good and she's breathing okay. And that was it, so.
Yeah.
Yeah, I just wanted to say, I had a brother that just passed away in 2022 out at Rocky Mountain House. And there was one room out there for a hospice care.
And he had outstanding service in there. I know they brought a meal into him, and he said, "Oh, I don't like the looks of that." And the nurse said, "Well, is there something you'd really like?" He said, "I love a bowl of cream of tomato soup and a glass of milk." Well, about 10 or 15 minutes later, she's in there with this bowl of cream of tomato soup and milk. And he had that, and he was so happy. They were at his beck and call. I saw him. He went in there the July 1st weekend, and I saw him on the Sunday. And I was still able to talk to him. He was still coherent in that. He took care of a lot of business stuff and that for me. And I was able to talk to him and about, end of life and this stuff, eh? And he said, "I've had a good life, Mark," and he said, "We've had some good times together." And I just felt good after that. Well, then I didn't see him again. And I thought, well, thank heavens I had that visit with him, because that just really helped. So I can't say enough about the hospice. It was just great. Yeah, thanks.
I'm sorry.
It's okay. Thanks for explaining all that. I've been in a hospice a couple of times, not from other person, but just out of curiosity to see how things are here. Because I'm slowly learning how this country has systems in place for all the people, right? So talking about the palliative care, the biggest thing I'm concerned about, and I went through myself, is the guilt on the part of the caregivers. You know what I mean? Where we make the biggest decisions for them, and that guilt might hit you at some point of time during the process of all this, or it might hit right away, saying that you might have, maybe I should have done something better, or I would have waited for some more time. Especially how fast the things can change when the person is in the palliative care, right? So that's when I am like, okay, is the hospice only taking care of the caregivers just for that moment, or is there any system in place where they check on them after the thing happened and they're grieving for the person they lost? Especially, I'm very worried about the people who lost their loved ones during COVID, right? Where they never had a chance to say a proper goodbye or hold a funeral. And now they're coming out and they still are dealing with all that, because once things get to normal, that's when you realize, right, that, yeah, it should have been different, So does the hospice have anything in place to check on those people to see how they're doing and what kind of resources they have if they need some emotional support and mental challenges that they're facing now? And the second thing, I want to put it there again, like the second part is the multicultural part, where there are so many people coming from different faiths and beliefs and different religions, different beliefs. So how the hospice is dealing, like how they are taking care of all those things too, because they have their own rituals to do, right? So, sorry, yeah, you can explain a little bit of that. Thank you.
Yeah, in terms of looking after families after someone has passed, they do have some counseling. It wouldn't be something that would be available to someone in the community who wasn't involved with the hospice, whose family may have passed, but they never were at the hospice. But for those who came to the hospice, they would continue to see them for a time as needed following that. As far as other religions, other cultures, the hospice is quite open to having people of whatever faith or whatever culture attend. They have like a chapel room that is available for anyone to use. It doesn't have to be necessarily a Christian faith. It could be other faiths as well. So they're very open to that sort of thing. I know there was one case of an Aboriginal family that was involved, and there was a real problem with the smudge ceremony because of the smoke alarms. So, I'm not sure how they got around it, but I don't know, they might have gone outside or something.
I know in our facility, it's the policy.
In our facility, it's the policy for smudging that maintenance be involved and turn off the fire alarms during that time. And we have to do fire wash, so anyway.
Kind of logistical.
Yeah, at least something is there in place, right? Yeah.
Hi, well, as opposed to Colin, I lucked out with my husband with the home care because as soon as Dalt lost his legs and couldn't stand and get to the washroom, the home care nurse was right on and got us a bed and our doctor got us a bed in the hospice within 24 hours. It was awesome. I did not want him to go to the hospital, so I feel so blessed. And he was, in spite of the fact that he knew it was kind of the end, when he got there, it was during COVID, and he was a very social man. So he enjoyed being with the nurses and whatever else. And restrictions were very, very strict at the hospital. At the hospice, it was a little less strict, and each of the rooms have a patio or something, and so we could open the door and people could be outside because it was summer, and we just move his bed, and so it was a lovely, if you can have a lovely time at the end of life, it was very, very positive. And the grief, very peaceful. The grief counselors were right on and followed up afterwards all the time.
Yeah, every room at the hospice has a patio where they can go out into the open air. And just across the street, there's a beautiful memorial garden there that has been set up. And patients can be wheeled out in a Broda chair, taken outside. And yeah.
I'm just wondering, when we ran up against Palliative, it was very much framed as this is the end. So I'm wondering, how do you transition people from regular care to palliative? How do you talk them through that?
It's a difficult problem. It's more easily done if it's introduced when they're still getting active curative care. That palliative care can be part of that. That the philosophy of palliative care is incorporated in managing their symptoms. It's often not as much, it is a difficult decision sometimes for patients. Often families want to push, where the patient may say, I've had enough, I don't want any more, I don't ever want to go to the hospital again. I hear that all the time, but families will say, no, Mom, you gotta go. You gotta, we have to send you back. And on the other hand, a lot of specialists have the same kind of attitude. So we often find the cancer specialists are the ones that are most reluctant to introduce palliative care, which is a real shame, because they see it as, now I've finally failed, and so I'm handing it over to the other team. And I think that's a very unhelpful way of viewing it, a very backward way, but that's kind of their mindset. And we want to keep giving more. There's another therapy we can try. We've tried all these different chemo protocols. There's one more that was studied in Switzerland. Let's try this one. So there's that kind of attitude rather than recognizing, no, we're not going to win this battle. Let's focus on improving the quality of life as much as we can for as much time as is left.
Is it the patient's decision?
Oh, it's always the patient's decision, but sometimes they get enough pressure. Like no doctor will give a medication to you without your consent. You always have the right to refuse. But very often there's a lot of pressure that's put on them. And I said often by families as well as by physicians.
That's why you need to sleep. Oh, so good thing you do. Your goals of care is laid out. Is it on? Can you hear me? Yeah. Oh, okay. Can you hear me now? No. There we go. When my daughter passed away, I really was in a state where I wasn't, and didn't know how to handle it. And the hospice here in Red Deer had a wonderful program. They had the grief program. And I just want to say that that is also something that you should be very proud of, because I know it helped me along the way, and I hope it's still continuing.
Yes. Just a comment about sometimes people will be admitted to the hospice with the expectation that they will die within a week. And then we find with the care that they receive there, they end up lasting for months. And
sometimes they get readmitted to long-term care.
yeah, that's right. Sometimes they get admitted to hospice, and then 4 months later, they're still there and they're thriving. So they get them sent back to long-term care.
I'm up again. Actually, Dr. Bromley, you were my husband's doctor for the last 12 months. And that man has a lot of patience, believe me, because my husband would go along to his walker and stop in the office doorway, and I'd go and say, now come on, don't knock. Oh, he visits. The last time I saw him there, Stan wanted to go to the bank, and I said that it just forecast 6 feet of snow, so I'm not driving. So off to his room he went. He was quite happy. But thank you for your care. You were wonderful. And the hospice, I've had 2 friends die in the hospice, and they're in and out. Now, how's your pain? Do you have pain? They'd come in with a cup of tea, or the care is wonderful. The people that work in the hospice are angels without wings. They really are.
A lot of times the credit goes to the medical staff, but it's really the nursing staff. Like Edith was on 32P at the hospital in the palliative unit for quite a few years.
10 years, probably.
Yeah, 10 years. It's the nurses who provide the care, and we kind of get the glory of having.
And as a nurse that worked in palliative care, I have to tell you it was a privilege. You know, to have that person and that family share their lives when you're doing the care, it is a privilege.
I hate using this.
Have to swallow it. I'll take it.
My husband died 3 months ago of a freak accident, and he broke his neck. It was a bad fracture, and it was a horror. It was a horror show from the Monday till the Friday, and he was in hospital. We went up to Edmonton by ambulance, and they couldn't do anything, and they sent us back. And then they tried all sorts of tests, and then he was in such agony, he had dementia. And the Thursday, the doctor said that it could be that they could do something for him, but it would be so long and arduous, and they couldn't guarantee anything, or we could just make him comfortable. And that was Thursday night, and he died Friday night. And other things shut down, but it was such a, it's like a horror movie, you know. But the hospital, they moved him into palliative for the last day and that. But I had Randy and Colin and Jeff stayed with me the whole time. They never left my side, and Chris too. And it's just, I'm having trouble. It's like a movie still in my head. So, but you know, it's really important to have the support of family. My family's all away, so I was very fortunate to have Val and Bob and the family with me, and Shirley and Randy. It's yeah. I just wanted to say that making the decision to just make Alec comfortable was the worst thing I had to do in my life. Mark Merritt sang him home. And that was really meaningful too, so thank you.
Thank you.